Hello. Hey, everyone. Hope you guys are doing well. Again, this is Dr. Delon Canterbury. Today with me, I have an amazing guest, Dr. Brittany Lamb, and she is a well-versed ER physician who can speak so much to the harms of overprescribing. Again, I am the founder and CEO of Geriatrics. Today, we're having a little bit of a new twist on how I usually do things, but we're going to just have a casual convo. And I'm going to let Brittany just share a little bit about herself. We'll dive into what she does and what got her in to the dementia caregiver and patient advocacy space. So, Brittany, so awesome to be on with you. How are things going with you? How's your week?
Things are good. I've been working night shifts, so I'm a little bit tired. My schedule's a little weird, but I'm happy to be here. Thank you for having me. Yeah, I'm super excited to talk about this. I think that we have a huge issue in our country with seniors being overprescribed medications, and we need to tap into our resources, every healthcare professional that's available to us. So, you guys out there, pharmacists, I mean, we need you, and we need more people like you to be doing this type of work to advocate for our patients. So I've been an attending ER physician for about 5 years now. I trained in Alabama and I did my residency there. And I've always had a passion for aging folks. I just love them. I love their energy. I love to see vibrant aging people because that's what I want for myself. That's what I want for my family members. And I've always been passionate about making sure that we're making decisions in the ER that reflect people's preferences and their values. And I don't think there's enough of that planning that's happening. And I think that the gap in it is that people don't understand the treatment options. And if you don't understand the treatment options, then you can't make informed choices. So because I'm an ER doctor, because I do critical care, I can kind of bridge this gap for people between primary care and then kind of advanced care planning and like the legal side of things with advanced directives. So that's like for all seniors, that's important. For all of us, it's important, but it's even more important when someone has dementia because they're not able to speak for themselves at a certain point, and most of them are going to live for a while and for a long time potentially and develop other medical problems and issues. And so they need somebody that's going to speak up for them, be confident in doing so, speak with what they would say and what their preferences are, and actually figure out what they are, because so many people don't do that. So that's the work that I'm doing for dementia family caregivers, is helping them create a plan for how they're going to make medical decisions on behalf of their person.
I love it. I love it. Are there other doctors who do that type of work that you're doing?
I haven't found anyone yet. To be honest, I've just, the healthcare system is really, it's causing me a lot of moral injury personally. And so I, searched for a while to kind of figure out what else I could do, to quite honestly, like supplement my income and potentially move away from having to practice in the hospital, having my own thing that I can do where I have control of it. And I feel like I'm able to create impact and make positive changes. So I came up with this whole thing on my own. So I know other physicians are doing like direct patient care, and kind of trying to break away from the system a bit, but I don't know of anyone doing exactly what I'm doing. So.
Gotcha. So I'm curious, I've shared how much dementia has hit my grandma and how much her care was kind of thrown to the wayside, right? She was given a prescription that was while she was in a nursing home, an antipsychotic, and it basically masked or worsened her dementia symptoms. She had mild cognitive impairment. That led to her being eventually kicked out. My parents had to figure out care and bring her back home and waste all this time and money. So why does dementia specifically, why is that a topic that kind of resonates with you, and what got you into that space?
Yeah, I mean, I have family personal like experience with it. My grandmother lived with us when I was growing up. She had vascular dementia. So I saw the challenges in the adults in my life. I was not a caregiver to my grandmother. I was a teenager, just running around, being a teenager. But that was part of it. My great grandmother had dementia as well. I volunteered with patients with dementia when I was in college, and then in medical school worked on advanced directive stuff. But I think it's mostly just been my experience in the ER. Just seeing the care of patients, it's so challenging.
Yeah.
It's so challenging in the emergency department to take proper care of patients with dementia. Quite honestly, we don't really. And it's because the system is not set up to support us to do so. It's just so busy. The ER, geriatric emergency departments, I think are coming. I think that's something, that will happen in the future. Wow. Yeah, there's organizations like I think American College of Emergency Physicians has like a whole group of people that's trying to push for geriatric specific emergency departments, because the care of geriatric patients in the ER is it's very complicated, as I'm sure as you know. But yeah, I think that it's just seeing how every medical decision we make for someone with dementia is different than if they didn't have dementia. Like all of the clinical decisions that we make, we always have to go back to the fact that they have an underlying dementia. So it's just, those people needed the most help I felt in the senior space. And that's kind of like the people that I like to work with the most. So
yes.
Yeah.
Yes, I love it. So you're my favorite type of person because you see the BS and you're ready to act and jump on it and leave a pretty decent salary. But like you said, that moral injury is what resonates with me, is that I just spiritually wasn't showing up the way I should, right? I wasn't happy. I hated my life. I hated what I was doing. And I felt subtly that I was kind of just killing people in a weird way, like I'm signing off on a script and I know it's 3 different anticholinergics, and I'm just like, well, and it's like, well, you can advocate as much as you can, but sometimes
your hands are kind of tied when you're within the system. And so, I'm still practicing. I'm not planning on really leaving anytime soon, but it would just be nice to go in there because, like, I really want to be in there, and not because financially I have to be in there, because that's my job, and I do love being in the ER and being a part of the team and helping people. When I actually get to make a difference, it's so great. There's nothing better than saving someone's life. I mean, it's really awesome. But there's my personal issues. I just see the big picture in healthcare and medicine, and I just want to do something else to help. So, but yeah, I wanted to ask you some questions.
Yeah, what's up?
Okay, so about deprescribing, like those topics. So I wanted to ask you about the genetic testing and how you feel like that would benefit patients with dementia, especially the people that are earlier on, trying to preserve quality of life, trying to preserve life, prolong life. A lot of, in the beginning stages, people have a good quality of life, like they want to keep living. So, like, what do you think about using genetic testing to help those folks?
Yeah, I'm definitely a huge fan of genetic testing for all, but I feel our seniors are kind of getting left behind because, well, they're older, so why not worry about PGX or genetic testing? I think that's wrong. That's flawed. The truth is, we know people who may be in this subset of patients tend to have all types of other chronic issues. And guess what? They're usually being managed by some type of medication. Now, when we're talking directly about dementia and some of the genetic markers, right? We know that there are certain significant genes that can lead to basically having Alzheimer's. We know that APOE is a big one, and there's several other pathways, right? The truth is, we know that there's also variability between the 5 drugs out there that treat people who have dementia directly. And it's crazy. You have either like a 20% people may respond, up to 80% variability for people who take the standard dementia treatments like your donepezils, your Aricepts, and other types of meds. And they're really sadly only 5. So we know for fact, genetically, there are markers that can lead to this. So why wouldn't we think to consider the medications having some type of genetic response? And the truth is, when you have all these dementia patients who are taking, they're depressed, or they have anxiety, or they have pain, a lot of them have pain and may not be able to tell you that they have pain.
Right.
They're being treated by drugs that generally are cleared by, genes that have some type of effect on how they respond. So I'm more of a, everyone needs this. I don't care how young you are, how old you are. So there's definitely an impact of getting this, at least to make sure the meds are doing what they're supposed to do.
Yeah.
We are still a little bit behind in giving, I would say, like hard and fast recommendations for someone who may be, a poor responder for this one drug. We're still researching and understanding that. But the truth is, these patients are the ones who are on tons of meds, and 90% of us have some type of actionable genetic marker that can lead to worse or better outcomes depending on how we guide therapy. So again, to your point, it's important. It's a part of what I do with geriatrics. And frankly, it's to me a key piece of deprescribing. I mean, here we are assuming thousands of people in our country are going to just take the same medicine and you're going to hope it works the same. When we know for a fact everyone has different backgrounds, different ethnicities, different exposure, environmental factors. And generally, meds work maybe 35% of people who take something. Then you got those who have rare side effects for a small 5-10%. And you got another 30% who are just like, I need to have double the dose because it's not working. The way that works for, blood pressure, pain, psych is very much the same analogy for those with dementia. So I think it's super important to get genetic tested and consider what that can do for other therapies for your patients.
I love it. I think it's a great idea. I've been telling people for years about genetic testing for the psych, like mental health piece of things, because I run into that a lot in the ER. But honestly, I'm learning about this too. Like, I mean, I'm an ER physician and I'm 5 years out of, being in a teaching hospital. So you have to take it upon yourself really to educate yourself and keep learning. And I love to learn, which is part of why I'm a doctor. So, I've started to tell patients that they should get genetic testing, like all of my patients. But I used to just talk about more about mental health because I had personal family experience with that. My sister is a psych nurse practitioner. So it's, it was more relevant to me. Plus, I feel like patients really struggle to do the trial and error with those medications. And that ties over to dementia patients and seniors in general too. It's like, if you know something's more likely to work for you, then you can try that initially instead of going through the rigmarole with all these different medications for anxiety and depression, the mood stabilizers and all that stuff. So
yeah. And I mean, who has time to waste, right? Like we're not young anymore. Like we're not here just, let me just try this, for 6 months, failed, and try another for 3 to 6, fail. You end up getting burned out and you end up losing trust in the care you're receiving.
Oh yeah.
And that psychologic piece is really key to buy-in and to driving change. So why not choose a cost-effective means that's widely available to give you at least a clearer picture of what can best help you? And to me, it's mind-blowing, but that's what we're here for, is to discuss like options we can mitigate this risk today and then educate each other, right? I can learn from you, you can learn from me. There shouldn't be any ego. There shouldn't be your title, what are your credentials? And I love seeing more providers who see the importance of genetic testing and how this can really have some lasting impact.
Yeah, totally.
So I'm curious for you, you're in the front lines on the ER, surviving COVID. How much has polypharmacy played a role in maybe some of your admissions for some of your seniors, or like how do you even like follow up or, I don't know, refer to their PCP to fix that if that's
I'll tell you, it's very challenging. The ER is a fast moving machine. It's not efficient. It's not designed to be that way. And so my job and my role when I'm in there is, see people, treat them if they need treatment, stabilize them if they need stabilization, and then can they go home or do they need to be in the hospital? And a lot of seniors get admitted, and then I know we have pharmacists in the hospital. I've seen them in the emergency department doing medication reviews with patients. And so it's really, really important. But in the ER, when it's really obvious that it's a medication side effect, it's like a slam dunk. We know what this is. But I think there's a lot of times that we are not able to identify in the emergency department that it is medication related. I think that slips through the cracks a lot of the times. And I think I don't always think that it gets addressed even in the hospital, because the way the hospital works, right, is if you get admitted for vomiting and diarrhea and you're, older and you're weak and you can't walk, and you get admitted, you get hydrated, they make sure your electrolytes are okay, your kidney function's not getting worse, you're able to eat and drink, your belly's okay, you don't need surgery, you're not bleeding, and then they're like, okay, bye.
Bye.
They treat the problem that is right now, and they don't, the system is not set up to look at people as a whole anymore and to take time. There's too many pressures on people, like documentation and all these external pressures on providers. And so the time spent with people, speaking with them and having conversations and educating them and asking them questions and all that, so that you can get to the root issue with it's probably partially due to medications. It doesn't happen often. So I'll tell you that blood thinners are a huge thing that we see. I mean, people fall, they go boom, they bleed in their brain. And I'm always like, it's okay if we're on blood thinners, that's fine. But our goal of care, especially with dementia, needs to be clear and obvious if we're going to continue the use of blood thinners. And it is a delicate thing to talk about, because strokes are hugely disabling. And people are on blood thinners often for atrial fibrillation, which increases their risk of stroke. But there's that. And then the other thing that I see commonly with medications is people who get dehydrated. And then they keep taking their blood pressure medications. Their blood pressure gets lower, they're hypotensive, and then they're not getting blood flow to their kidneys. So then they get a kidney injury. And I mean, this, but for people out there that are listening, this is why we need to have medications need to be a part of our planning especially when we're caregivers. We need to own the medication list. And I talk about this all the time. I feel like, yes, healthcare is broken, but also as a society, we need to step up and take ownership of our medical problems. We need to know what medical problems we have. We need to know the medications that we take. And I had a patient a couple of nights ago, and it was actually not a patient with dementia, but it was an older patient. Her son was in the room, and we were just chatting about her medications. She was on Cardizem, and she didn't know she had atrial fibrillation. So that's crazy. For everyone out there, don't worry about that. But but yes. So he's in the room, and he tells me that he had open heart, bypass surgery, and that he can't tell me a single medication that he takes. And he says this with kind of a badge of honor. And I'm just and I in the room, I said, full stop. Let's take a stop. Let's time out here, sir, ma'am, everyone in here. Whenever you leave this hospital, if you only remember one thing, please know the medications that you take. Know, because if you don't understand what you're treating in your body, what your medical problems are, you can't understand what you're at risk for.
Right.
And if you don't know what you're at risk for, you can't make a plan for your future. And that's I feel like a broken record talking about this, but the part of the problem is that people don't even know what they're taking.
My God. Yeah. The educational piece. I mean, you cannot expect a 15-minute sit down after invasive surgery as your end all be all of education for now you have heart failure. Here's all your meds. Now go.
Yeah.
No, you gotta have a long convo. You need to have follow-ups. You need to have a 7-day check-in. You need to do so much to educate, because this is a new thing. You cannot assume someone with a new health condition is now their own healthcare provider. Come on.
Exactly.
That's hard. But the problem is, like you said, we don't have a system that embraces that. There's some, academic medical centers that require a pharmacist sit down and a med assistant, and you go through them all. But that's once, right?
Yeah.
Once, maybe twice. And if you call, they don't answer or whatever. However, education needs to be ongoing, right? And this is a key to having patients know, okay, this is a side effect. This isn't normal. That's a big thing. There's times I've heard somebody say, I just thought it was me being whatever. And it's the number one sign of heart failure, whatever. Things that could be prevented. But again, why I'm so drawn to you, and I think vice versa, is our love for this education, this patient advocacy, this let's break it down and actually take the time to really retrain so that they can have those better outcomes later.
Yeah, I totally agree. And that's why I want to transition into asking you something else about medication reviews.
Yeah.
So I think that people are not using the skills of pharmacists enough. And I don't think that people understand that you all are trained health professionals. And I don't think people understand the depth of knowledge that you have. I think that's a general misconception
For sure.
amongst everyone. But I wanted to ask, like, what would you recommend? Like, say somebody can't afford your services, particularly, like, how can they logistically maybe approach a like retail pharmacist to try to help them get a medication review?
I love that. First and foremost, I'm not a fan of the big box pharmacies. So if you have a local, independent, family-owned mom and pop pharmacy, go there first. I'm going to always say that. One, they just care more. Two, they're not in it for the money. They're in it to help you. And generally, they will take the time to sit down and provide that value. You can still get some of those rare gems in your traditional retail pharmacy. And I think a lot of us pharmacists have that in our heart. We want to do that. The problem is we can't always do that in certain environments. So one, I still say, visit your pharmacist or call your pharmacy at an ideally very slow time. So either first thing in the morning or like 30 minutes before they close, and it's like not too late. Just and then ask them, hey, you may be busy now, but is there a time you're going to be in that we can just sit down and have a 20-minute talk and just go over my mom's meds or whatever? That's what I would do. That's logistically the easiest thing you can do. Now, if you want a quick answer like ASAP, one little trick I've learned having been a pharmacy manager is that you don't have to call your pharmacy. If you have a chain, for instance, you can call a Walgreens 3 hours behind, and maybe it's 24 hours or something, and everyone is connected. So you could still have a pharmacist give you advice. Now, I wouldn't, 24-hour overnight pharmacists are already, like, they're overnight, so they're doing all the little things that are busy. But keep in mind, you can still call people like after hours. Like, there are pharmacy stores that are required to be open 24/7. So no matter where you are, you can have someone do a med review. Thirdly, people who are on Medicare are actually required to have an annual wellness visit. And as a part of their annual wellness visit, there's supposed to be a thorough medication review, not a "are you taking this" list. That is something you can also ask for, and that's required. And you can control your fate, guys. So if you have an appointment coming up, you say, hey, doc, Granny's on 20 meds. We want our next visit to just be a strictly med visit. You can ask that. And that is actually included and required as a part of an annual wellness visit. So that's something to also keep in mind as well. But I say that, and why I stress this is that pharmacists are still the most accessible healthcare provider in the country. Everyone, 90% of our country is within 5 miles of some pharmacy. So there's usually a doctor or pharmacy behind that counter who wants to help you, right? So just be mindful that they're dealing with COVID shots, ridiculous work environments, pharmacy benefit managers trying to screw them out of a reimbursement, low staff. Healthcare is burning right now. So let's be real. That's just the honest truth. But I advise that pharmacists are, I feel, the best kept secret of healthcare. Like, we can do so much. Let's use them, and let's not just fall prey to this guy in a white coat counting by fives, putting your name on a bottle. It's way more than that. Which is why I do what I do with geriatrics. And so I can help anyone, basically anywhere, with this type of service. So that's an issue. You can always contact me. And, I know some of our seniors are on fixed income. So I actually, as a courtesy, I do provide flexible payment plans for those who may be financially distressed as well.
Yeah, I think everyone should go and talk. I think everyone should talk to you.
Yeah.
They're going to take up all of your time.
That's okay. That's okay.
But yeah, I think it's so underutilized, and you guys are the experts in drugs. So it's like, why not pick your brain, and why not have you weigh in and advocate? And it's just,
Yeah.
It's so important.
It's so important. And again, this comes down to the ego thing too. It's like I've met so many amazing providers, doctors, NPs who are like, oh my gosh, I had no idea this existed. I didn't even know I could leverage pharmacists like this. I didn't know I could work with them and he can actually bill under my name for incident to billing codes and get them revenue for their clinic. There's so many creative ways and care models that this can be done.
Mm-hmm.
Like, it's not really a joke. And I mean, there are people who do this now and they contract with pharmacists. They do their med reviews, they do their wellness clinics. We can do a lot. And I love providers who don't look at the ego. I've had only one guy, some guy in Maryland, one nephrologist who was so rude to me about being a pharmacist, just giving my little advice about, hey man, I'm worried about these dosings for his renal function. And he's like, I'm a nephrologist. You don't know what the hell you're talking about. Take your goonie off. He told my patient to take your pharmacist goon off and stop bothering me. I was like, all right, okay, fine.
Oh my gosh.
He's coming from another place. It's not my job to combat that. My job is to advocate for patients. You can call me names all day. I don't care. But yeah. So
sounds like that patient may want to consider a different nephrologist.
That's what he did. Which he did. Eventually he left. And he wasn't getting the best care anyway. But
I think a lot of physicians are really just burnt out. And I think that's one way that people react when they're just overworked and overstressed. And it's like, who is this person coming in and telling me that I don't know how to do my job? I'm doing the best I can. I have all this thing, and so, we have bad days. We make mistakes. We're not perfect. We're all human beings. And so I check my ego at the door. I listen to my patients in the ER. If you listen to people, like, they will tell you what is wrong with them. That is the thing I teach, people that follow me around, nurses. I like to, I teach nurses and techs and, because a lot of our people are trying to do other things when they're coming through the ER for a certain time period and they're going on and doing other things in medicine. And it's just like, if you listen to people and you hear their story, they will tell you like what the issue is, Yeah. And so I love when I actually have the time to do that, but sometimes it's too busy, I mean, like when I worked Memorial Day weekend, I think I worked a 9-hour shift and I saw like 30 patients by myself, And so it's when you're doing that, that the care is not going to be the same as if you see 10 patients, right? It's like I can spend way more time and spend time educating. And when you see 30 patients, then you're kind of just like, okay, well, we're going to stabilize people and not let them die, and then figure out if they can go home or they need to be admitted to the hospital. And that's part of the reason why I decided to do this, is because I do like to teach and talk and
for sure.
Help people. So I think those are the two big things I wanted to talk to you about, was medication reviews, like logistics of that. Do you have any, but do you have any like direct questions that you would recommend that people ask a pharmacist about their medications? Like when they go to them with the list, like, just look at this list and tell me if this seems appropriate. Are there too many? And obviously drug interactions. Those are the like kind of things that you would like, broad questions.
Yeah, great point. I guess I'm not trying to mince words here, but you do want a pharmacist who at least understands geriatric care if we're dealing with a patient. So not every pharmacist is going to know all the geriatric stuff, right?
Sure.
Just like how there are different types of doctors or different types of pharmacists or oncology pharmacists, etc. So at least have that in the back of your mind a little. I wouldn't say just ignore someone who gives their opinion, but the number one question is my loved one taking too much? Like, are all these necessary? And so my general hard cutoff is when people are on more than 5 medications, which is damn near everybody. I train my patients and my clinicians to teach their patients to say on every visit when they see a doc, what can I do to get off of some of these medications safely? What can we do to stop some of these meds? What can we do to just get rid of one and then come back later and get rid of another? Can we do a trial to stop a medication for 3 months and see how my labs do or whatever? And if I'm fine with quality of life and side effects or whatever, can we continue? And that's the thing. This doesn't even take me being a pharmacist. This is just like, are you on more than 5 meds? Yeah. Are they life saving? No. Oh, you got
Right.
intervention. So when you're going to ask a pharmacist, you know, can you remove my meds? Here's what I think is going on. I think it helps to get a little background of why you're concerned. You know, is there some kind of harm or immediate side effect that might be jumping out at you? So definitely mention any changes. I mean, any dose increase, decrease, stopping, starting. If anything has changed with your loved one, whether it's diarrhea to dehydration, you should mention that. Everything is kind of a red flag when it comes to geriatrics. You got to just know all the details, right? So be open, be transparent, and apart from just asking for side effects and drug interactions, another thing I like to use is the Vione method. So this is a mnemonic that I actually teach as a part of my Deprescribing accelerator, where I'm teaching, again, people like you, clinicians, nurse practitioners, people who are senior care facing, and how they can integrate and sustainably implement Deprescribing. But Viome is actually a methodology that was developed by the VA. And it's an acronym that looks at assessing medications for patients. So essentially, V is for vital. Is the medication vital? Like, does the patient have to absolutely have this to live? Right. What's I? I is sheesh. Drawing a blank. I, is it important? Like, it's not vital, but does it significantly improve your quality of life? Right.
Sure.
Those are the two main things. Now, okay, next, is it optional? Is it like a omeprazole for GERD or something, or heartburn? You've been on it for 5 years. That's an optional drug. You don't quite have to have it, right?
Yeah.
N is for it's not even indicated. That's like being on an antibiotic you had, I don't know, this is rare, but 5 years ago, and you're still on an antibiotic, or something that you had that was no longer needed and you're still on it. That's a big one to potentially stop.
Yeah.
And E stands for, does every medication you take have a diagnosis? Is there an actual real indication that you're using the medication?
Yeah.
So many times people are just on stuff because they've been on stuff, right?
Yes.
And I see that a lot with supplements. Like, there are times where you really need supplements, and there are a lot of times you don't. You're wasting money. It's just for your feel goods, right?
Yeah.
You don't quite need that. So VIONE, or Vione, is a VA model that's actually being used within our VA systems now. I'm pretty sure this is going to be nationally done. But this is what they have been used to systemically and actually sustainably reduce polypharmacy in vets. So they are significantly lowering meds and saving the costs associated with them using this. So it's an easy methodology, but this is what I have in the back of my mind. Are the medications vital and life-sustaining? If it's not, you may not need it. Is it important, but and it improves your quality of life, but do you really, is it necessary, right? Oh,
yeah, risk versus benefit.
Boom, there you go. Risk versus benefits, right? If it's optional and there's no major impact on your life, whether you take it or not, do you truly need it? Probably not. And not indicated, meaning you've already completed treatment in the past, but you're suddenly still on it. You don't need that, right? And does every med you use, does it really have a diagnosis or indication for why you're using it? So that's my clinical methodology. When it comes to patients, it should be like, am I on too many meds? Is it improving my life? Is it saving my life? Do I need it?
Yeah, it makes perfect sense. I think I've been kind of doing that naturally.
Nice.
And
Yeah,
I teach my clients, like, you have to write down all the medical problems.
Yes.
And once you have the medication list, I tell them, like, go Google the medicine and try to figure out why your person is on it. Write it down. That way, like you said, every medication needs to have a purpose. There needs to be an intention behind the use of that medication. Otherwise, why are you taking it? So
let me add.
Yeah.
There also needs to be a timeline. I forget that. Every medication needs a timeline. Like, some drugs are going to be like, you have cancer. Okay, you'll need that for quite a while, right? I'm not going to downplay that. But some meds, it's past their prime. It's gone to pasture. You don't need those Tums anymore. You don't need that ranitidine. You don't need that naproxen you've had for 5 years for that one sprain you had playing ball.
Oh, please no,
Yeah.
don't take naproxen every
Please
day.
don't. Please. No, don't do it. Don't do it. But
I
I
see
think
complications from that. Over the counter medications, NSAIDs,
yes.
all the time in the ER. People don't realize, and they come in with GI bleeds, and they don't realize. And then I'm like, how are you using ibuprofen and naproxen, which is Aleve? And they're like, oh yeah.
Yeah, right. And they have no clue because they're not told this,
I
right?
know.
And
I
even though
know.
they want to go and ask the pharmacist, sometimes that line is too long, or there's so many factors apart from that. So one of my gripes with our healthcare system is, why the hell are we waiting for the last stop in the healthcare channel from doctor to pharmacy for all the shit to hit the fan? Like all the issues, all the PAs, all the side effects, when you can have a pharmacist with the prescriber before you write the script and at least have a little quick, all right, will this work? What do you think?
Yeah.
You can have every right as a prescriber. Guess what? Pharmacists, we don't want to be prescribers, but we want to help. And we want to help those who don't have access. And it shouldn't take someone almost dying, or one of my own patients who's had 2 strokes, who had he had a genetic test, we would have known he had these rare markers where he would not respond to normal blood thinners, and he had to be on warfarin. Like, there's so many examples of this.
Yeah.
So we only wait till someone is incurring all these costs on the healthcare system and, I don't know, dying before we jump to making a change to how we do things. So I'm just like, we gotta do better. We gotta do way better than this. And you as an ER doc, I love your perspective because I feel like I'm not just speaking alone. I feel like I'm not just speaking myths. It's like, this is it.
We see all the holes in the healthcare system, any age, any medical issue, mental health issues, substance abuse issues, everything. Like any medical issue that could ever happen to somebody, we see it, so we're kind of like the watchdogs for our healthcare system in a way. And that's why, like, what I do is I feel bad for primary care doctors and specialists kind of ragging on them. I know they have to churn through patients, which is to make money. And it's just, it is what it is. Right. And so, I rag on them a bit, but like, it's frustrating to me as an ER doc when I get people into me and they're in a crisis mode and they're not able to make decisions. And like, this is all part of it. It's like, there's no time to do planning and talking and having these big conversations and preventing these disasters, because like what you're talking about with medications, it's also happening, like just general health emergencies. Like if you look back, you're like, oh yeah, this was foreseeable. Like, and maybe we couldn't have stopped it from happening, but we could have changed medications. We could have changed your overall health and your sleep and your eating. And the root cause of issues in our healthcare system is like not being addressed. Like people are they're not being made to be healthy and overall well. It's just like we're just treating diseases, and it is broken. But I also think that we have to deal with what we have right now, and it's going to take time to change things. And so for me, I'm like, please come to me and let me help you understand what you're at risk for. And let's make a plan for how we're going to make medical decisions instead of waiting until you're in the ER and I'm asking you if you want to start critical care on your loved one who has dementia. Like, we have to decide this stuff ahead of time. As it's also like helping healthcare workers, because we are incredibly like stressed out and traumatized in a way. Like COVID really traumatized us because, especially with dementia. I mean, I can't tell you how many patients I saw that had terrible COVID. They had respiratory failure. They're, and then they're delirious on top of their dementia, and we're having to sedate them in order to keep these masks on their face, and then we're calling, do you want them to be intubated? And the people have never even thought about it. And it's so sad and heartbreaking to me, because as healthcare workers, we feel like we're almost like torturing people, and we're wondering, do they want this? Like, would they want this? And I think we all have a bias. Everybody in healthcare has a bias. And I think the people that work in the hospital, we have a bias towards less care. And it's because we see people suffering and we do things to them that are not comfortable, like while they're in the hospital, right? And we have to continuously remember, I talk to people all the time I work with in my team, like, remember, this person's really sick right now, but we don't know what they're like when they're not sick. So they have dementia, but like maybe their normal day to day is actually pretty good. And now they're just really, really sick.
Right.
I just want to know that what I'm doing is what people want. And that's what it comes down to. Like, that's why I'm doing this. I want healthcare workers to feel good about what they're doing to people. It's just, there's so much to talk about and unpack, but we have to deal with what we have. And what we can do is use pharmacists, do medication reviews, plan in advance for the medical emergencies that are likely to happen to us, and use alternative care resources. I think people are going to have to start like reaching out to people like us instead of just relying on traditional models in healthcare if they really want to advocate and step up for themselves, and protect themselves.
Yeah, man. I mean, you really can't say it any better than that. And the planning piece, even I struggle with that for my loved ones, trying to get them to talk about the advanced directives. How do you want to handle the after, the et cetera, your assets, your life? What do you want? It's already a hard conversation, but it's even better to have someone at least start the convo early, so you're not doing that while you're already stressed, frazzled, dealing with a pretty stressful situation. But I guess one thing I wanted to speak on as well was you and I are speaking to the importance of value-based care. We know that it should be the future, but truthfully, like 92% of all of our operations are fee for service in our model. That's just what it is. Deprescribing, what we teach people is that you can literally make this a sustainable, monetizable service. Like any other service, you can still sell that and generate revenue. I guess, where in the pipeline do we start with deprescribing when it comes to the provider and the prescriber? Because they don't really learn it in school. And that's what I'm seeing is no one has a clue. And we're kind of all grasping at, well, let's just play with it and see what happens. And we're not incentivized to get people off. However, if you get someone off of a medication that may be worsening, or a DDI, a drug interaction, or a drug like a naproxen in a heart failure patient, that could have led to money saved from your intervention.
That's what,
like, the indirect costs are there, but like, how do you market that? How do you tell providers to think about this and not say, I'm just stressed, I don't have time for that?
Yeah, I mean, no one's ever asked me this question before, so I'm just kind of answering this on the fly. But what I think is that in order to do that on a big level, you would have to get insurance companies to incentivize that.
I agree.
That's how I think you have to go after it, because that's who's paying everybody. So I think you go to the insurance companies and you tell them, look, this is going to not only save people, this is going to save healthcare dollars. It's going to also save people's lives, and it's going to increase patient satisfaction, which is like a huge deal. It's going to increase people retaining, in your insurance. That's true. So I think you go to them and then you have to work with providers in a way so that you're not talking down to them, like the nephrologist. You just have to speak to them like, we're here to help, and we want to kind of take this off your plate. We want to be an advocate and another tool in the toolbox, and like, we want to help your people. And some of it may be the medications, and like, let's just take a step back, because I think part of the issue with healthcare is that people want a quick fix, and oftentimes that quick fix is coming in a medication. And so it's providers being stressed and not having the time to sit down and have conversations with people. So when they tell them that they have some sort of symptom, they're just like giving them a medication for it, instead of wondering, well, maybe it's the medications they're on already, especially with seniors. And but I mean, that's how I feel that way about antibiotics. Like people go and get tested, or go and have like symptoms of infection for like 2 days, and they get put on antibiotics, and it doesn't really make sense. It's not clinically indicated, but a lot of people get, people overprescribe because they don't have enough time. So I think going to insurance companies is the way to fix that. Maybe.
I completely agree. Sorry, I have one last thing, because this is such a cool combo. We could clearly talk for hours.
That'd be good.
Um,
I hope
my
someone's
God.
listening to this.
Yeah, we've got plenty of listeners. We've had plenty of comments. We've had one
Oh,
talking
cool.
about, I love this. Polypharmacy is a great concern. We got a shout out on LinkedIn from Kristen Grenion Clark. We got 3 people watching us right now as we
Oh,
speak,
cool.
and
Hi.
2 others commented earlier. But I want to know your thoughts on this. And this is, I mean, this can lead to another combo, but the New York Times had this crazy release done last fall where they talked about the increase of seniors having a diagnosis code for bipolar and schizophrenia. So, what these nursing homes were doing was falsely diagnosing these people with conditions you normally have when you're like a young adult. And so that gives them free reign to write antipsychotics, or basically write medications that just control them and sedate them. And so they don't have to bother them. And their nurses aren't, worried about rounding with them because now they're just sedated, they're knocked out. So the New York Times investigated this over the last decade, and they found there was a 21% increase in the false diagnosis of bipolar and schizophrenia in seniors. And this is across like the most reputed nursing homes to the lowest of the lowest. Even the 5-star Medicare ones and the low-star ones are all doing this. What the hell do we do?
So that's nuts. I mean, I wish my sister was in on this conversation because like I told you, my sister is a psych nurse practitioner, and she actually worked for a short time after she graduated in a nursing home, and she did not do that, but she made comments to me about how she felt like they were overbilling and over visiting and some stuff like that, some shady stuff. But it doesn't surprise me, which is sad. I didn't actually know about that, but it doesn't surprise me at all. But it is completely crazy that they would be diagnosing people with bipolar and schizophrenia at the as seniors. That's completely inappropriate.
Crazy.
That's not how that works. That's nuts. Like, that's fraud.
It's so bad. It's so
really bad. And like the medication issue, the antipsychotic issue in nursing homes, it's a staffing issue. It's a lack of training issue. It's a, these facilities, their businesses, they want to keep their patients. They don't want them to fall. They get in trouble. It doesn't surprise me that they're trying to sedate them. Do I think that's right? Absolutely not. It's not right. It's wrong. I don't know how to fix it. I think that we have a huge problem in our country because our patient population is aging, right? And we're going to have just like more and more aging folks, and we don't have enough bed space for them in facilities. And we need to get people to age in place safely for as long as possible. I don't know how we're going to pay for it. I don't know how we're going to help caregivers of people who are seniors keep them home and keep them safe, because caregivers lose money. Their own health is affected. Their mental health is affected. So many issues. But the nursing home situation, honestly, it makes me like want to go and run nursing homes, because I know that I would do the right thing for people. And I think maybe more people our age, or where we are in our stage in careers, may kind of try to do stuff like that. Like, that's kind of what I hope, is that just people find passion in this and find taking care of aging folks, like they find joy in that, and then maybe they'll fix it. I don't know.
I don't know either. I don't know. And I make a point to teach this because, again, a lot of what we end up doing is just asking why. Why are you on this? Why did this happen? Why are you on? Why? And trying to get to the root cause of all these issues. And frankly, like you said, the writing's on the wall. The Medicare fund is up in 2026. And we have an aging population with less senior care managers, less senior care providers. I actually talked to a nurse practitioner yesterday about this very same thing. And she had a loved one around the Kenosha area where COVID kind of first broke out initially, where they're finding a mixture of the housing crisis in Seattle, a very expensive area anyway.
Oh, yeah.
But now they're converting their hospital ward. They're converting one of their inpatient clinics just to be a geriatric nursing home, because all of these seniors are homeless and all of these seniors have all these issues. They can't afford to just be where they were. So now they're just going to the ER. They say, we're just going to make a ward and just, now I'm a nursing home.
Wow.
Like, these are clinicians and now they're nursing home. It's like,
yeah,
we don't talk enough about this, but this all reminds me of a Netflix movie called I Care a Lot. If you haven't seen it, check it out.
Okay.
It has Peter Dinklage from Game of Thrones and some other people. But essentially, it talks about how these two nursing home owners scam all these seniors into becoming a member, and then they end up, while they're admitted, seizing their assets and like buying their homes and doing all this. It's darker than it's a satire, but it's so telling to our healthcare, senior care space.
It's very tough, and I think advocacy work is incredibly important, but for me in particular, I need to make this part of my life grow in order to do that more. And it is something that I would like to do in the future. So do more work with advocacy. When I was in medical school, I did some like healthcare policy, stuff like that. I was trying to get into that. And then my father was diagnosed with cancer, and then I did residency, and it was like this whole, life hits you, but it is something I'm interested in. But, you have to be careful. You have to be careful when you're an employed doctor and an employed person in healthcare that you don't say something that's offensive and potentially going to get you fired. So, it is what it is, like, we do the best for the people right in front of us. And that's how I sleep with myself at night right now. I just take care of the person in front of me, and then I'm working on this on the side, and hopefully it will work out. And we'll just, then I can do more work to help make bigger changes. That's kind of like a long-term goal of mine. I would, really like to make some big changes in healthcare, because I think that's the moral injury for all of us, is that we see the big picture, we see these big problems, and we're like, how can we fix this? How can we do it? And there's no quick fix. There's no simple fix. It's a huge industry, lots of lobbying, insurance, the government, so much regulation, so much red tape. I think it's going to take a team of people like decades.
Like us.
Yeah, like us. I do agree. I mean, I think we have the time to give. I mean, we have a lot of life left, right? And we're experts in the field. So I wish that we were consulted more. The boots on the ground people would be helpful, but anyway.
I love it. Well, Dr. Lamb, I'm going to trust you with all of my needs if that day comes. Guys, if you haven't checked her out, please connect with Dr. Brittany Lamb. Message her. She's willing to help you with those plans. She's willing to get you set up for the future so you're not caught blindsided, okay? Dr. Lamb, it's been a pleasure. As always, we're always going to be friends. I love talking to you. We got to do this again.
Thanks so much for having me.
Absolutely. Absolutely. And thank you all for joining in, learning about how deprescribing can play a role in saving some seniors' lives. Leverage your pharmacists, but more importantly, leverage those who care. Get those patient advocates out there and check in with us. So you guys be safe. Take it easy. Much love. Again, this is Dr. DeLon Canterbury, CEO and founder of Geriatrics and founder of the Deprescribing Accelerator. You guys take care and see you next time.
Bye, everybody.
Later.